Endoscopic ultrasound-guided hepaticogastrostomy, practical tips and tricks. These are our disclosures. Endoscopic ultrasound-guided hepaticogastrostomy has gained traction as a reliable and safe method for biliary drainage in patients who cannot undergo traditional transampullary procedures. Here, we highlight key clinical and technical tips for successful EUS-HGS using devices that are currently available in Western countries. We will now review key concepts that apply to each step of the procedure, starting with pre-procedural considerations. Appropriate patient selection is essential to achieve good clinical outcomes. Common indications for EUS-HGS are patients with distal biliary strictures where the ampulla is inaccessible due to malignant or benign stenosis of the gastric outlet. Patients with surgically altered anatomy in whom the ampulla is not accessible via balloon-assisted ERCP. And patients with high-grade bismuth type 1 strictures that have failed transampullary access. In addition, EUS-HGS may be used as a method for supplementary biliary drainage in patients with complex biliary strictures such as bismuth type 2, type 3, and type 4, where the left intrahepatic bile ducts cannot be accessed using traditional ERCP. Obtain pre-procedural cross-sectional imaging. Unfavorable factors that may increase the risk of complications are large volume ascites, as is seen here. Liver tumors that are located in segment 2 or 3 that fall within or close to the EUS-HGS tract should be avoided. Patients with portal hypertension tend to have extensive collateral vessels around the stomach, and the risk of bleeding with transmural access is high. When hyperbilirubinemia is the primary reason for biliary decompression, it is important to assess the volume of upstream liver parenchyma that will be recruited via EUS-HGS. Patients with liver atrophy will not achieve significant improvement in serum bilirubin. This is, however, a moot consideration when cholangitis is the primary reason for drainage. Have your equipment ready before you start. Having your equipment easily available and ready at hand will minimize delays between procedure steps and reduce the likelihood of intraprocedural biliary leakage or redundancy. Choose a patient position that works best for you. The following slides highlight important considerations about patient positioning. A prone position with neutral AP fluoroscopy is preferred by many, but a supine position is acceptable as well. When in the prone position, the liver capsule and gastric wall do not oppose each other, and you may require additional forward force from the transducer. In this position, however, the scope is in a more stable position and is assisted by gravity. Particular attention must be paid to the dead or intraperitoneal space between the liver and the stomach, as it may result in guide wire looping or stent dislodgement. It is also important to note that in a standard prone position, due to the shoulder prop, the right side of the liver is generally located on the anti-gravity side. This causes preferential left-sided pooling of contrast, and a large volume of contrast must be injected in order to fill the right intrahepatic ducts. A slight downward inclination of the right side of the fluoroscopy table lowers the right intrahepatic ducts and results in better filling of the right side. This obviates the need for overinjection and may reduce the risk of bile leak. Step 1. Puncture site selection. Key considerations when choosing between segment 2 and segment 3 bile ducts are as follows. Both intrahepatic bile ducts in segment 2 and segment 3 of the left lobe of the liver are suitable sites for puncture. B2 is more cephalid, is easier to access with the scope in a neutral position, is more favorable for guide wire manipulation, but has a higher risk of transesophageal puncture and mediastinitis when compared to B3, particularly if one is not careful about avoiding the diaphragm. B3, on the other hand, is located more caudal, is less favorable for guide wire manipulation and tract dilatation, but has a lower risk of transesophageal puncture and bile reflux esophagitis. When technically feasible, accessing B3 close to and upstream from the B2-B3 junction with the endoscope in a bent configuration is considered by many experts to be an optimal puncture site. Choose the right intrahepatic bile duct. A target intrahepatic bile duct of greater than 5 millimeters is generally recommended as this is associated with a higher rate of technical success. Experienced endosonographers may be comfortable with 2 millimeters or more in select patients. The distance between the liver capsule and the targeted bile duct should ideally be 2.5 to 3 centimeters. If the distance is too small, there is an increased risk of bile leak. On the other hand, if the distance is too large, there is a lower chance of technical success. Avoid transesophageal puncture. Transesophageal puncture should be avoided as far as possible due to the risk of pneumothorax, mediastinitis, bile reflux esophagitis, and food occlusion of the stent. The likelihood of transdiaphragmatic or transpleuritic access can be minimized by the following. One must accurately identify the squamocolumnar junction and check judiciously for the presence of a large hiatal hernia. This can often be done with careful retroflexion of the endoscope. In the absence of a hiatal hernia, a puncture site that is 2 to 3 centimeters below the squamocolumnar junction will ensure an intra-abdominal puncture and minimize the risk of transpleuritic access. In the presence of a hiatal hernia, however, the squamocolumnar junction is frequently located above the diaphragm and does not correspond with an intra-abdominal location. In such cases, if the bile duct is punctured at the level of the squamocolumnar junction, the needle may inadvertently traverse the pleural space. In such cases, EUS may be used to identify the hypoechoic right cruise of the diaphragm that is located immediately anterior to the aorta and terminates a centimeter or two above the celiac artery optic. The level at which the right cruise terminates marks the start of the abdominal cavity. Once identified, this point can be marked via EUS injection of radiocontrast or application of a hemoclip at the level of the transducer. This can then be used as a reference for the remainder of the procedure. Avoid traversing the gastrohepatic ligament. The hepatic ligament can be identified as a homogeneous hyperechoic structure that is located between the undersurface of the liver and the lesser curvature of the stomach. The ligament contains medium caliber blood vessels and may sometimes contain lymph nodes, as is seen here. Traversing this ligament should be avoided if possible, as this may result in positional kinking and angulation of the stent. Optimize the angle at which you approach the target bile duct. The angle between the longitudinal axis of the FNA needle, depicted by the red dotted line A, and the longitudinal axis of the target bile duct, depicted by the blue dotted line B, determines the direction of the guide wire. An angle of approach that is greater than 135 degrees facilitates unrestricted passage of the wire towards the hilum. In B2, the angle is generally achieved with the scope in a relatively shallow and straight position. As seen here, the angle of approach is quite favorable during B2 puncture, and the wire passes without difficulty towards the hilum. In B3, however, if the scope is in a shallow and straight position, the angle of approach is unfavorable. A favorable angle is obtained with the scope in a deep or caudal and flexed position. This position is achieved by inserting the scope 4 to 5 centimeters beyond the diaphragmatic cruise, turning the big wheel all the way down and pulling the scope slightly backward until a target intrahepatic bile duct is identified. These are two examples of B3 approach in a straight, shallow, and deep flexed position. As seen in the video on the left side, the scope is deeper, completely flexed, has a more favorable angle of approach, and the guide wire easily passes towards the hilum. On the right side, you have the scope in a shallow and straight position with an unfavorable angle of approach, and the guide wire passes peripherally. Biliary puncture. Avoid introducing air into the biliary tree after you have punctured it. As seen here, air bubbles when inadvertently introduced into the biliary tree can significantly impair echo visualization. Withdrawing the stylet and priming the needle with contrast or saline will minimize the likelihood of pneumobilia. Avoid applying too much pressure on the gastric wall when screening for blood vessels. As seen here, blood vessels are clearly visible on Doppler, and they almost completely disappear when the transducer is pressed firmly against the gastric wall. Use of a balloon is sometimes helpful in such settings and will allow for echo coupling to occur without the need to apply extra force on the gastric wall that could mask underlying blood vessels. Be prepared to puncture through a fibrotic bile duct and decompress the biliary tree before injecting contrast. Puncture of the target bile duct can be particularly challenging in patients with fibrosis or biliopathy. In such situations, a rapid forward thrust of the needle may be required to gain access. It is not uncommon to puncture beyond the posterior wall of the bile duct. If this does occur, apply suction when slowly withdrawing the needle until a bilious aspirate is confirmed. The biliary tree should be decompressed before the injection of contrast. This will reduce the risk of bacterial dissemination in patients with cholangitis and intraprocedural bile leaks. Aspirated bile may then be sent for microbiological studies. Step 3. Contrast injection. Use diluted contrast. As is seen here, using water-soluble contrast that is diluted to 50% with sterile saline or water will result in better visualization of the guide wire and a more uniform distribution of contrast within the biliary tree. Recognize an intravascular injection. Prompt recognition of an intravascular injection is important. As is seen here, soon after the injection, the contrast follows a typical vascular arborization pattern and pools in the parenchyma of the left lobe. This should be promptly recognized and the needle should be repositioned. Step 4. Guide wire insertion and manipulation. When the guide wire is passed towards the periphery, the following tips or techniques are helpful to redirect it towards the hilum. The looping technique. Here, the guide wire is advanced until the tip is fixed in a terminal side branch. The guide wire is subsequently pushed forward while torquing. This typically results in formation of a loop. If the guide wire is kept close to the needle while doing this, the wire occasionally flips towards the opposite or hilar side of the liver. In this particular patient, despite trying this technique multiple times, the wire did not flip. Needle impaction technique. In this technique, while leaving the guide wire in place, the needle is withdrawn slightly until the bevel exits the bile duct wall and is positioned 2 to 3 millimeters within the liver parenchyma. In this position, the guide wire immediately exiting the needle tip is supported by the liver parenchyma and stays aligned with the longitudinal axis of the needle. This minimizes the risk of wire shearing and allows the operator to pull the guide wire back while only the curved tip is left within the bile duct. The tip can then be rotated towards the hilum. Caution should be exercised not to withdraw the guide wire tip from the bile duct during this maneuver. Scope manipulation. In this case, despite getting the wire to turn towards the hilum, it could not be advanced. In such cases, while leaving the needle tip in the bile duct, the scope can gently be advanced deeper while turning the big wheel up. This changes the orientation of the needle and generally favors a direction towards the hilum. And if all else fails? If all of the above mentioned measures fail, withdraw the needle and guide wire and repeat puncture of the bile duct using a more favorable angle towards the hilum. As demonstrated in this case, not withdrawing the needle completely while adjusting the scope and needle angle may result in a lower likelihood of bile leak. Using this technique, we were able to redirect the guide wire and advance it towards the hilum and subsequently into the bile duct. Step 5. Tract dilatation. The tract from the stomach to the intrahepatic bile duct is comprised of gastric wall, 2 layers of visceral peritoneum, liver capsule, liver parenchyma, and bile duct wall. Pathological thickening of any of the layers could lead to difficulty in advancing instruments. Identify and dilate all potential points of resistance. It is important to identify and dilate all biliary angles and narrowings, starting with the most distal narrowing. It is easier to pull a previously used balloon than it is to push it. Anticipatory dilatation of all sharp angles will ensure subsequent smooth passage of a stent. In addition to aspiration of bile before the injection of contrast, use of the segmental dilatation method will help minimize the risk of bile leak. Traditional methods used for tract dilatation involve simultaneous dilatation of the entire tissue tract from the bile duct to the stomach. As is seen in the illustration on the left, this allows for unrestricted leakage of bile through the dilated liver parenchyma into the peritoneum. In the segmental dilatation method shown on the right, the tissue tract is dilated separately on the bile duct and the gastric side, leaving 2 to 3 centimeters of undilated liver parenchyma. This undilated area acts as a stop valve that prevents the leakage of bile. This is an example of segmental dilatation method. As seen here, the bile duct is first dilated separately and a healthy amount of undilated liver parenchyma is spared. The balloon is then retracted towards the scope into a position where it traverses the liver capsule and gastric wall. This area is then dilated, leaving 2 to 3 centimeters of undilated liver parenchyma. This is the endosonographic view of the same. Step 6. Stent placement. It is vital to minimize intraperitoneal or dead space. As the stent is introduced across the gastric wall, the liver is typically pushed away and the intraperitoneal or dead space between the gastric wall and the liver is increased. This space can be decreased by pulling the stent backward into the scope during deployment. Before deploying the stent, it is important to reduce the dead space by advancing the stent deep into the intrahepatic ducts and then withdrawing it back towards the scope until the stent tip is at the desired position of deployment. The dead intraperitoneal space is highlighted here on fluoroscopy. Notice that as the stent is pulled back, the gap is significantly reduced and the liver capsule is once again in approximation with the gastric wall. This allows the operator to maintain control and may significantly reduce the risk of wire or stent dislodgement. If the stent does not pass easily, adjust the scope, and if that doesn't work, redilate the tract. As is seen here, the stent is hung up at the liver capsule. This is remedied by pulling the scope up and changing the angle of the guide wire. After passing into the liver parenchyma, the stent is once again hung up at the level of the bile duct wall and does not pass despite position change and applying tension to the guide wire. In such cases, a balloon may be used to redilate all potential points of resistance as seen here. Be sure to dilate all sharp angles and potential points of resistance. Upsizing the dilatation balloon can sometimes be helpful in such settings. Following a second series of dilatation, the stent passes comfortably into the liver ducts. Position your stent for success. The distal tip of the stent should ideally be located 2 to 3 centimeters within the selected intrahepatic duct, and the proximal tip should ideally be greater than 3 centimeters within the gastric lumen if deploying under endoscopic guidance, or greater than 3 centimeters within the therapeutic channel of the echoendoscope if deploying under sonographic guidance. Only after this optimal position is achieved should the unsheathing process be started. Important considerations during stent deployment. As the proximal flange deploys, it is common to visualize a first point of narrowing that represents the location where the stent exits the intrahepatic biliary tree. With the proximal flange anchored in place, the stent should be pulled slightly backward for the remainder of the deployment. This maneuver will pull the liver even further towards the gastric wall. Continue to deploy the stent while maintaining the distal flange in a steady position. As the stent continues to unsheath and expand, it will expand against the gastric wall. This fixes the stent in place and is usually identified as a second waist or narrowing closer to the echoendoscope. The remainder of the stent can then be deployed within the channel of the endoscope or under direct visualization. When deploying under fluoroscopic or sonographic guidance, the stent is completely unsheathed within the channel of the endoscope. The stent sheath is then pushed forward into the channel. This pushes the gastric wall away from the endoscopic lens and the remaining stent is deployed into the gastric lumen. Note that visibility at the end results from pushing the stent forward and not backing away of the endoscope. This is an example of deployment under direct endoscopic visualization. The stent is advanced deep into the liver and pulled back into a desired location. Once this position is achieved, the stent is unsheathed under direct visualization. The gastric pinch or narrowing is then identified on fluoroscopy and the stent deployment is completed once again under direct endoscopic visualization. Avoid blocking segmental bile ducts. A fully covered stent, when placed across the liver hilum or deep within the intrahepatic bile ducts, may result in segmental biliary blockage and focal obstructive cholangitis. Partially covered stents and fully covered stents with fenestration should be considered in such patients, especially when treating for malignant indications. After stent deployment, if there is concern that a segmental duct has been blocked, an anterograde cholangiogram may be obtained. As demonstrated here, a standard stone extraction balloon is used to occlude the gastric side of the stent and contrast is injected. As seen here, contrast flows easily into segment 2 intrahepatic bile ducts. In this patient, however, we observed no contrast flow into segment 2 ducts despite using a fenestrated stent. While comparing the patient's baseline cholangiogram with the post-stent deployment cholangiogram, we easily identify the absence of any contrast in segment 2 ducts. This confirms segment 2 intrahepatic biliary blockage. In such cases, while the stent can be readjusted, one must be cautious not to inadvertently dislodge the stent. An alternative approach is to leave the stent in situ for 3 to 4 weeks and readjust it after the tract has had time to mature. In conclusion, EUS-HES is a viable option for biliary drainage in select patients using devices that are available in Western practice. An understanding and implementation of the technical nuances highlighted in this article should help Western endoscopists navigate the complexities of EUS-HES and ensure optimal outcomes. Thank you for your attention.